Dear chairs, dear colleagues, allow me to start by presenting my PhD thesis topic, New Insights in the Management of Partially or Completely Edentulous Patients. I am Yasir and Muhammad, a dentist from Iraq, first year PhD student. My supervisor is Gabor Varga, my SMS is Petrana. My vision is to provide the patient with a durable, aesthetic, and long-term comfortable prosthesis. My mission is to investigate the recent evidences regarding implant abutments and fixed and removable prosthodontics. According to that, I have two ongoing projects. First one is comparing the long-term success of zirconia, PEK, polyether ether ketone, and titanium implant abutments. It started in September 2023. The second one is investigating the efficacy and safety of added soft liners on removable dentures. First one is a systematic review and meta-analysis, started in September, and I plan to be able to submit it in August of this year. Well, in 2020, there is more than in a study done in USA, more than 240 million Americans have at least one missing tooth, and these require replacement, and the best is to do with implants. So there is an annual growth rate of 5.7%, and there's approximately 500,000 American individual undergoing implantation annually. So there is a need of durable aesthetic implant abutments. Abutments can be made of a variety of material. The gold standard is titanium, but it has the advantage of a gray material and lacks aesthetics. There is also zirconia, which is a white material, softer than titanium, but it is rigid and it's subjected to fracture once the force exceeds the proportional limits, no ductility. Also, there is the PEK, which was used as temporary abutment material, but now it can be used as permanent. It is white in color and has smoother surface than titanium. So our clinical question is that what is the performance of polyether ether ketone, zirconia, and titanium implant abutments in clinical practice? According to that, our PICO framework is that P is the patient with implants, the intervention is zirconia or PEK, the control is titanium, and we have multiple outcomes as we will see later: survival rate, technical complication, biological, and aesthetics. Our hypothesis is that zirconia and PEK are non-inferior to titanium regarding durability with better aesthetics. Our clinical implication is that improving the durability, aesthetics, and functioning of implants support the prosthesis. We started our systematic search in November 2023 in 4 databases. This is our search key. We started with more than 11,000 articles, ended up with 33. One is added after citation and reference chasing. This is a picture of our Prisma flowchart. So according to that, we divided the outcomes into efficacy, safety, and aesthetics. It will be of great value if we had about cost, but we don't. And also we divided it into 2 parts. First one is conventional analysis of zirconia versus titanium, where there is plenty of studies, and also we have the network analysis of 3 types of abutments: zirconia, PEK, and titanium, as there were only 5 studies concerned with PEK. So first of all, first we decided to include RCTs only, then we decided to include also non-RCTs to see the overall estimates, and also we did all in one subgroup. First, we decided to do subgroups according to the follow-ups, but then we have only one group to see the overall effect, as we have also a limited number of studies. So as we see that survival rate, and in this we have conventional comparison between zirconia and titanium. The total is 9 studies, 7 RCTs, 2 non-RCTs, and it showed that more survival was in titanium when compared with zirconia, with an odds ratio of 0.7, although this was statistically non-significant. Then we have the network analysis. In the network analysis, we included only the RCTs. So as we see that there are 9 RCTs to compare, to do the network analysis, 7/2, and there was indirect analysis between PEK and titanium. And as we see the rankogram here, we show the area under the curve. Of course, we have to tell the statistician whether the high value is good or the small value is good. So according to that, we have the P-score. And as long as it is close to 1, this means that the material is favorable to be used. And it shows that titanium was the best in survival and the least was zirconia. And still, it was also statistically non-significant, but we can see that PEK showed comparable results with both of them. Then we have the technical complications, where they measure the technical complications like screw loosening, chipping of crowns, veneering fractures, and others. And we have 6 studies, 5 RCTs, 1 non-RCTs, and it showed that more technical complications had occurred with titanium, yet it is still not statistically significant. Then we have the aesthetic, which we'll see that it has 2 outcomes. First of all is the delta E, which measures the mucosal color change when compared with the adjacent natural tooth. As long as it is small value, it is better. Higher values is bad, as it is close to the natural tooth. And in this, we have 4 RCTs and 4 non-RCTs, and it showed higher values with titanium. So zirconia was favorable regarding aesthetic, and it was statistically significant. And we went on the network meta. There was 5 RCTs to compare, and PEK and zirconia showed comparable results, and titanium was the least. Then we have the papillary index, which also we categorize it as aesthetic, where the papillae grow to fill the black triangle, and it showed that higher values was with zirconia, so it's favorable, but it's statistically non-significant, but could be of relevant value because all the studies have on one side showing that zirconia is better in this field. We have also the bone loss, which measured on radiograph, and in this we have 10 studies, 8 RCTs, 2 non-RCTs to compare, and it showed more bone loss in titanium, but it's still of mean difference 0.09, maybe clinically and statistically non-significant. When we see it in the network meta, there were 10 RCTs to compare the 3 outcomes, and according to the rankogram and P-score, zirconia was the favorable, and titanium was associated with the more bone loss. Then we have the probing depth, which measures in periodontal probe to see the pocket depth or the probing depth. And also we have the conventional and network analysis. And the conventional analysis between zirconia and titanium, there was 10 studies, 9 RCTs, 1 non-RCTs, and it showed more probing depth associated with titanium compared to zirconia. In the network meta, there was also 10 RCTs to compare the 3 outcomes, and according to the rankogram and P-score, PEK was the favorable, and titanium was the least or the worst, so that's associated with more probing depth. Then we have the plaque index, which see the total availability of plaque around the abutments, and it was more with titanium. And when we compared with the RCTs and network analysis, PEK was the favorable, and titanium was the worst. And then the bleeding on probing, the last, which showed the bleeding of the gingival tissues as a sign of inflammation. And we see that it was more with the zirconia. And when we compare it with the network analysis of 4 RCTs, like PEK was favorable and titanium was the worst, although this was statistically non-significant. So, the strength is that there are multiple clinical outcome studies where multiple outcomes, follow-up periods ranging from 1 month to 13 years, and there is a possibility of network analysis of RCTs, but there was only few studies concerned with PEK, and we included some non-RCTs, and there also was heterogeneity regarding the measurement of some outcomes like plaque index and the bleeding on probing, as there are multiple indices, percentage, and others. So our main conclusion is that both titanium and zirconia are effective and safe. Zirconia is associated with better aesthetics, and PEK showed comparable results with both titanium and zirconia. Our implication for practice is that zirconia and PEK can be used as alternatives to titanium abutments with better aesthetics, and the implication for research is that more studies should be included concerning PEK and the cost effectiveness, as we know that PEK is the cheapest. And what is the difference between the customized and stock abutments? This is our progress in the manuscript right now. I plan maybe to be able to submit it in August in Periodontology 2000, which is the one journal. The second project is also a systematic review and meta-analysis, where there are more than 36 million Americans having no teeth at all. 90% having dentures, 50% replacing their dentures annually due to the frequent or residual ridge resorption and the need for a frequent lining. So one of the material of relining is the soft liners, which added a value of flexibility, cushioning, and shock absorption. So our clinical question is that, does the addition of soft liners improve the acceptability and mastication of the patient? the PICO framework that patients with removable dentures, the intervention is dentures with liners, control is no addition of liners, and the outcome is patient satisfaction, chewing ability and durability. And our hypothesis that added soft liners improve the chewing ability and the durability of removable prostheses. I hope to be able to submit the first project in August 2024 and the second one in January next year. And I'd like to finish my presentation with a quotation by Kobe Bryant that my parents are my backbone. They are the only group that will support me if I score 0 or 40 points. Thank you.
I would like to ask, in the first project, could you carry out any subgroup analysis depending on what kind of prosthesis is delivered on these abutments? Was it feasible with such a low number of studies?
And it was like we have very limited number of studies. Like even the number of patients are very little. So there was most of the results there was wide confidence interval. So maybe there was no like space for subgrouping regarding the prosthesis, regarding the mucosal thickness, regarding whether it is a ready-made or a stock abutment. So we have only like generalized the follow-up. Even the period of follow-up. First we did a subgroup analysis, first 1 year, second, but we have very limited results. So we want to see the overall estimate as a whole.
About your first project, that you compared the different abutment based on the aesthetic. But what kind of aesthetic was it? The white aesthetic of the final restoration, or the pink aesthetic, which can be visible through the mucosal layer of the gingiva? So did you make any differences between these two types of aesthetic?
There were in the studies, there were like white aesthetic and pink aesthetic, but like it was not collected. We cannot collect the data. So we have only the two outcomes: the papillary index, where the papilla fills the space and we consider it as aesthetic. And the second one is the delta E, which also shows the mucosal soft tissue, the pink, the soft tissue aesthetic, or the mucosal color change compared to the adjacent tooth.
Thank you very much. And did you make any differences in the thickness of the soft layer? Because I think the thickness of the soft layer can
Indeed.
Yes,
yeah,
influence the final result.
Of course, yeah, it has a value. So we see that we took the average thickness, like for example 2.3, 2.5, which was measured in the studies with the use of a file or something. So we took something average, because some studies like said only this measurement and some have 3 measurements regarding thick and thin, but we didn't have the chance to do subgrouping. So we took some average values for all.